Amir, I want to bring you into this discussion and ask you, so you have a young patient, FLT3 mutated, they've relapsed, you know you got to get them to transplant. Doesn't it just make sense to give them chemo to get them to transplant? I mean, don't these targeted inhibitors take longer? Do they get you in a deep remission?
Potentially. I mean, I think that, so there, just if I may start with some principles that have been alluded to, I think, in passing, which are very important in my opinion when it comes to FLT3 inhibitors. One is tolerability. I mean, I think there is a marked difference between tolerability of, say, midostaurin versus gilteritinib, or even sorafenib versus gilteritinib. I mean, midostaurin does cause a good amount of GI toxicity. I think it's uncommon for me to give midostaurin to somebody and not have them at least have mild GI issues. Whereas gilteritinib is much better tolerated. I think that's an important consideration. The other consideration is the type of FLT3 mutation. This is extremely important. Now that we're doing NGS panels, we're doing additional mutational testing, we're discovering additional FLT3 TKD variants. Some of these FLT3 inhibitors, as Mark just alluded to, don't really work. I mean, sorafenib, quizartinib don't have much activity in some very prominent TKDs that are found. And what I oftentimes worry about in the community when we see patients coming in with FLT3 mutations and potentially treated with FLT3 inhibitors for a mutation that would not be expected to respond to that FLT3 mutation. So I do think those factors are very important. Finally, we talk about ratify, and I think this question has come up multiple times in the past. What is a dirty FLT3 inhibitor like, let's say, midostaurin or sorafenib doing in these patients? Is it mainly having its therapeutic impact through suppression of FLT3 mutations? Or is it potentially having other effects on other pathways that it may be inhibiting? I think it's probably FLT3 because of the patterns that we have seen, but I'm not sure if that is completely the case. For example, the SORAML study showed that, you know, across the board, patients with or without FLT3 mutations seem to have some degree of response. The quizartinib study showed that patients with FLT3 wild-type disease have response. So these are all questions that have yet to be fully answered. The answer to your question, getting to a younger patient who may relapse, I'm not sure if it's clear-cut that I would necessarily combine it with chemotherapy. That question has not been sufficiently answered. So I could not fault somebody if they want to put the patient on monotherapy with gilteritinib with a remission rate that approximates 50%. You could potentially decide to combine it with an HMA. The data on that is emerging. It's not final. We don't know if it's substantially better. I suspect it will be better, but I don't have any definitive evidence to suggest that. I do not know if I personally would beat up a patient, even a younger one, with intensive chemotherapy and gilteritinib in the relapse refractory setting. Relapse refractory treatment for AML, the remission rate, as we all know, hovers around 40 to 50%. Even in younger patients, it's not, depending on the timing of relapse, is not necessarily that more impressive. So my own personal preference is to either give it as monotherapy or combine it with a hypomethylating therapy and try and achieve a response.
I would just jump in with one comment that, you know, sorafenib gets a little bit of a bad rap. It's not the easiest drug to take. And Mark always says that all his patients' hands and feet fall off. Mine don't do that. But I do think that that drug has magical powers in the post-transplant setting that are different. I actually think that both the scientific and the clinical data suggest that the post-transplant relapses, there really might be something important to consider for some patients with sorafenib that could actually be different from the others. So I just put that plug in that I think that sometimes it's just dismissed as well. It's old and it's not easy to take, but I actually think that that specific setting is one that is actually quite interesting, and especially in combination with HMAs.